So that's why I'm going to be giving a brief lecture on how to prepare for this. What's the format for MRCP Part 1 examination? What should be your resources or materials? And what are the exam topics that you frequently come, and how many questions from each of the systems you can expect? And just a basic guideline I will be discussing in very short form. So I hope by this time, I have a list of new candidates who will be joining us. Dr. Marianis Lara Gonzalez, are you present here? Lara Gonzalez? Okay. Dr. Ahmed Sami Sadiq. So all right. Asanul Haq is over there, okay. Elizabeth Sarkar, okay. Dr. Elizabeth Sarkar, can you hear me?
Yes, miss.
Okay, where are you joining us from?
I'm now from Dhaka, but usually I will join with you from Shatkhira.
Shatkhira, okay. Okay, so you don't have any time problem, right? Timing is okay, just like Dhaka, yeah. So that's fine. Okay, Dr. Vasista Dr. Vasista, not present here, I guess. Okay, Dr. Nanayakara, not present. Dr. Vishal, anybody present now? Okay, no problem. I hope you will be able to catch this session from online e-learning platform. This will be updated. So without further ado, first of all, I hope everybody knows about the entire structure of the MRCP exam. So MRCP exam is actually divided into two parts, the part 1 examination, the part 2 examination. Part 1 examination is entirely MCQ based. Part 2 examination is further divided into two parts, part 2 written examination and clinical examination. So part 2 written examination is basically very similar like the part 1 examination. What a problem? Sure. Okay, so part 2 written examination will be very much similar to the part 1, except for there will be some differences like maybe some pictorials can come, sometimes ECG tracing, interpretation of the ECG, echocardiogram, and cardiac catheterization, from the respiratory system spirometry data interpretation, and from the imaging there might be some ultrasound or sonographic interpretation, and from the nephrology there might be some histological slide interpretation. So it's a bit different from part 1 examination. I hope everybody who's joining us today is preparing for the part 1 examination, so we'll go into details about that. So part 1 examination is divided into paper A and paper B. It's a one-day exam, totally 6 hours. So each of the paper will be consisting of 3 hours, and in between these paper there is going to be 30 to 45 minutes of break depending on the center or the location. And each of this paper will consist of 100 questions. So thereby you will be facing 200 questions in total, and your total marks will be 1000, and your pass mark is it actually differs from one year to another. I think this is roughly around 520 for part 1 examination, and for part 2 written examination the passing threshold is a bit slightly lower. Anyway, but here my advice would be not to emphasize on your pass mark, because you want to get like a lot of marks here. That's how you can prevent from failing, because MRCP kind of like follows a scaled marking system. So not each of the question will be equally marked, okay? So the tougher questions will have more marks. Like instead of 10 marks for these tough question, they will be having maybe 12 to 15 marks, and the easier question will be marked less. So for example, the easier questions might be 5 to 7 marks, okay? So that's how they compensate for this level of question. So if you, for example, if you miss the tough questions altogether and you keep on answering the easier questions, then there is no guarantee that you'll be able to pass. So that's why my advice would be not to focus on which are the tough questions, which are the easy questions. Try to attempt all of them, because there is no negative marking, first of all. And secondly, the more you answer, the more chances of you passing this exam becomes more apparent, okay? Secondly, I would advise that once you're appearing for this exam, try to make yourself acquainted with, there are going to be questions that you probably have never read before, okay? There are going to be questions that you have never solved before. This is entirely new and this is completely normal, okay? Do not be overwhelmed, because and a series of 10 or 20 questions can be this much difficult. But I would say do not get disheartened, skip those questions and then try to get the correct ones as much as possible. Then after finishing that, you can go back to the difficult ones and try to solve them, like one by another. As much as you solve them, the chances of passing you gets higher and higher. So that will be my advice. And secondly, try to go through the mrcpuk.org website. There is usually like the format is very much well written over there, like how many questions you can expect from each of the sections. Like for example, the important sections like cardiology, respiratory medicine, gastroenterology, neurology, infectious disease, rheumatology, and then endocrinology, these like big sections from the medicine, okay, they will be having 14 questions coming from each of these topics, okay? And there are some like a bit less, not less important, but these are like a less important in a sense that they are quite super specialty. So you're not expected to know nooks and crannies about each of these topics. So those are like geriatric medicine, okay, oncology, palliative medicine. So these are these are important, but usually the questions come less frequently from these particular areas, like maybe 4 to 5 questions from each of these sections, okay? And in dermatology and psychiatry, I think the number of questions that come per year is differs. Sometimes lots of questions come from the dermatology section. I think in that diet, I would say the candidates are a bit luckier, because dermatology questions are quite straightforward. However, if the questions are coming from psychiatry, my personal opinion is psychiatry, getting the diagnosis is quite difficult. And it's usually not the scenarios are quite complex. There is no straightforward answer like in our previous MBBS level. So sometimes questions from psychiatry can come more compared to dermatology. It comes like every alternate diet. And there is another very big significant portion, that is clinical pharmacology and therapeutics. Very, very important. Lots of questions will come from there. And clinical science, clinical science questions will come from there for 25 questions. And clinical science comprises of basic anatomy, biology, physiology, pathology, biochemistry, which I've mentioned previously, genetics, and statistics and epidemiology. So this is just the generalized outline, but do go through the MRCP UK website. They have the full, there are some sample scenarios, and there is a very good format over there. So I think that will help you more. And in terms of how much time you need to study, I think it's a very subjective thing, because a lot of candidates are well mature and like maybe they have already been in the training section in their life. Maybe they're doing some sort of job, and after the internship they're attempting for this exam. So maybe they do require less amount of time compared to the newer candidates. But I personally attempted this exam right after my internship. My internship ended in July 2019, and I cleared the part 1 examination in the September diet in 2019. So I had like 2.5 months of preparation altogether. So I'm not going to be discouraging people who just graduated, because you can pass this, but your study time will be very much higher compared to others. Like if you're trying to go for this exam within 3 months preparation time, I would say you have to study hard. Like your daily study hours should be more than 10 to 12 hours, okay? So, but if you're preparing for a longer period of time, like for example, if you're preparing for 4 to 5 months, maybe even 6 months, then you can adjust your study schedule according to your work schedule, and maybe studying every day for 5 to 6 hours to 7, tops 5 to 8 hours is fine, I think. Okay, so how much time I have discussed about the exam planning. So for the exam planning, I'm just going to just give you general idea. So first of all, what you can do is like there are 2 types of basic strategies, okay? One is either you can go through the question bank first. And by question bank, I mean past test. I will be writing in descending order, okay? Past test, on exam, past medicine. My personal preference would be past test always, okay? So, and then after finishing each of the like cardio, for example, you're finishing the cardiology question bank, okay? So simultaneously going through the resource book. You can go like that. Or if you're going for like opting for a longer strategy, like you need more time, then you can go for like reference book first. There are going to be multiple reference book. Then after completing each of these reference book and lecture sheets, you can go through, like question bank solving attempt. So this is whatever the attempt is. I think I personally prefer this. This is my own personal preference. But as you're already taking the classes, I believe you're going for this strategy, like going through the reference book first and the lecture sheet and the video classes and whatever the class materials that have been provided to you, and then solving the question bank. Whichever you find easier, it's up to you. You can follow either two of these strategies, and this is usually a bit less time consuming. This is a bit more time consuming, that's all. And as for the resources, I've already mentioned the question bank names. Past is the most important ones because it's very much standard and it's very much up to date, and it reflects the real-time exam scenarios very closely, okay? But do not expect question repetition, okay? Questions will not be repeated. Sorry about that. Okay, questions will not be repeated, but similar questions will come, okay? And for example, and the resource books, I would say the lecture sheet that is being provided to you by Dr. Academy is good enough. If you want to add something to it, I will say Oxford Handbook of Clinical Medicine. This is a pocket book and very short and just and summarized information. And another important books would be Sudha Medicine by Honey. This is again very small book, very precise, to the point. There is no excessive information over there, so I don't think that it will be becoming like too much, or you have to put so much effort to finish these books. And a lot of people do go through like notes and notes. This is not really my personal preference, but I have heard like 9 out of 10 people will be going for notes and notes, and this will be my personal preference, okay? The combination of Oxford Handbook of Clinical Medicine and Sudha Medicine. This Sudha Medicine will help save your time, especially if you're trying to summarize every information that you have read so far within 3 to 4 days, okay? This book is going to be a lifesaver. But notes and notes is definitely going to take a lot of more time, and this is most recommended books, and I would say this has a 90% success rate, okay? All right, so I think I have summarized all the information so far I needed to. If any of the new candidates who are joining us for the first time, if you have any questions for me, you can ask me. Any questions so far?
Hello, good afternoon.
Good afternoon.
Riva ma'am, how are you?
I'm doing good, thank you.
Okay,
How are you
ma'am.
doing?
So, excellent. So, thank you very much for your nice explanation regarding the course material and the examination plan you have explained to our honorable candidates. So, I have a question on behalf of our honorable candidates. So, ma'am, you are providing a lecture notes which you are following topics wise. So some other books also you have mentioned to like the notes and the other reference books also. So there are some maybe may have some personal preference would be from any personal or individual preference. But what will be the exact guidelines for our candidates to follow That means first they will go through the lecture notes and definitely the unique lectures or the classes or the topics discussed by you and our honorable mentors. And after then going through the questions bank. So, and another thing which question bank you have already mentioned that past test is very important, and another question bank is also is very popular, like the past medicine also. So we have lots of contents also in our lecture notes also from the sources. So can you highlight once again to what will be the exactly the preparation procedure regarding the study materials? Because our honorable candidates always want that our mentors will guide you to a very concise way or
Okay,
the
I think I've got your question. I can go through it again. So,
Okay, thank you.
okay, all right. So your preparation strategy would be depending on the time of your preparation time, okay? So whether you're preparing for 3 months or 6 months, doesn't matter. Just go through the, first of all, like after finishing the lectures that is available right now, ongoing lectures given by the mentors, and these lectures will be provided on the e-learning platform as well. After going through these lectures, you can go back your home and open up the lecture sheet that is provided by the Doctor Academy. I think everybody by this time has the soft copy or the hard copy versions, okay? So then go through the topics that each of the mentors have already discussed. And after completing that, try to attempt the questions that are present in the back of the book of each of lecture sheet, okay? So there is usually like 100 to 200 question every time, and these questions are very much similar to past medicine, okay? And after finishing that particular, like for example, I'm giving you the lecture in infectious disease, try to go through the topics from the book, and you can, as an adjunct book, you can also use Oxford Handbook of Clinical Medicine or Sudha Medicine, whichever, but go through the topics that I've discussed, because I will be discussing these topics from the lecture sheet, okay? So that will be easier for you to catch up. And then try to attempt the questions from the back of the book that is provided to you, the lecture note, I mean. And after finishing that, once I'm done with the entire infectious disease, there is going to be 2 lectures on infectious disease. So after done with the infectious disease portion, like the lectures provided by the mentors and the lecture sheet that is provided by Doctor Academy and the questions that is in the back of the lecture sheet, okay? So once you're done with the infectious disease portion, after the 2 classes, then you will be having 7 days till the next specialty or the next topic begins. So during these 7 days, you should try to focus on using the other resources that I have mentioned. Simultaneously, try to utilize one question bank, okay? Like it could be past test, past medicine. You can maybe just, finish 100 to 150 questions, doesn't matter. Just try to attempt these questions from the question bank after you are done with this strategy. And this strategy should be followed once I'm giving you the lecture ongoing, okay? So the lecture provided by the mentors, and then go through the lecture sheet that is provided by the Doctor Academy, solve the relevant question from the back of the lecture sheet, and after completing the entire topic, then you will be having 7 days till the next topic arrives, and during that 7 days, try to solve the question bank. Start with any question bank, could be past test, past medicine, whatever you prefer. And then for like adjunct resources, you can take the Honey or the Oxford Handbook of Clinical Medicine. I hope that was clear.
Thank you, ma'am. Thank you for nice explanation. Thank you very much. You can start the session, ma'am.
All right.
Ma'am, I just wanted to ask you one thing.
Sure.
How can we order this Sudha medicine book by Henny? Because I was not able to find out, find on Amazon.
Okay, there are some PDF versions for now. Are you just starting your preparation?
Sorry, ma'am, I could not hear you.
Okay, I just asked, like, are you just starting your preparation? Like, at which level you're, is it your first class?
No, ma'am, I was attending the classes earlier, but
Okay.
in the middle I have got some health issues due to which I was hospitalized for a very long time. So I have resumed back again.
Okay. It's okay. So my advice will be like you do have the lecture sheet, right? That is provided by
Yeah,
the Doctor Academy, the offline, the hard copy or the soft copy.
right, ma'am. Yes, yeah.
Okay, yes. Go through those topics first. And Sudha Medicine by Honey is a very small, like very gist summarized book. So, like, I think if you go for that book in the very beginning, it will be a bit tough to get all this information because that's a very gist information. So go through the lecture sheets first because these have like more elaborative approaches. So after you're done with that, you can either order online the Sudha Medicine, or you can just try to see whether there is like these books are available in your local shops, or there are some PDFs available in different, like MRCP groups. You can collect that from there as well. Okay.
All right, ma'am. Thank you.
But do go through the lecture sheet first because these are more elaborative approaches. So it will help you understand easier. If you just right away go through the Sudha Medicine, it will be a bit difficult for you to pick up the information. Okay.
All right, ma'am. Thank you.
Okay, no problem. So I think I will be starting my class now. All right. So before the infectious disease, first of all, how many questions you can expect from infectious diseases? 14 questions altogether, okay, number one. And it will be scattered through the paper A and paper B. And resources I've already mentioned, like the lecture sheet and the question bank and the resource books, you can use them as an adjunct. And the 14 questions after that, what are the important topics from infectious disease? First of all, sexually transmitted infection. This is widely prevalent in the UK. So that's why sexually transmitted diseases are quite important in UK. So you can expect so many questions, especially chlamydia, okay, gonorrhea, HIV, and syphilis is plus minus. Especially chlamydia. Do not, if you once you are done with this, and if you are like revising these topics, do not forget sexually transmitted infection, especially chlamydia, okay? Because the treatment will make you confused, like what was the actual treatment. All the antibiotics, you know that these are all bacterial infection, you have to go for the antibiotic, but there is a difference between the first line antibiotic treatment, and once the first line is contraindicated or the patient is allergic to the first line antibiotic, then what will be the alternative treatment? Because these will be coming frequently in your question in the part 1 examination, okay? Number 2 is HIV, not as a part of the sexually transmitted infection, but rather complications, like different types of HIV complication could be different types of opportunistic infection. Cytomegalovirus infection, pneumocystis jirovecii, very, very hot topic, or pneumocystis carinii, and neurological manifestation of HIV, different types of complication, and another one will be toxoplasmosis. Okay, so number 3 hot topic would be gastroenteritis or GI topic. This is a 3-star topic, very important. These are, I would say, 5-star topic. Gastroenteritis, the watery diarrhea, malabsorptive diarrhea, and like bloody diarrhea, the different types of culprit organism, and you have to focus really, you have to focus a lot, especially on the incubation period, depending on the incubation period. Okay, number 4 is sometimes questions from botulism, tetanus will come. This is a 2-star topic, and fungal infections are also quite important. And sounds weird enough, but worm or parasitic infections, these are quite important for part 1 examination. Okay, so these are the most important part of the infectious disease. Although as surprising it may sound, tuberculosis, although this is a very prevalent infection in in Bangladesh, India, or the Asian countries, or the like African countries, tuberculosis is a very prevalent infection. As this is not a prevalent infection in the UK, so that's why they really do not bother about this routinely. So we will, however, we will definitely go through tuberculosis, but you don't have to go through the very detailed information on tuberculosis, okay? So we will start with a relatively easier infectious disease now, that is the syphilis. So, all right, as you can already know that syphilis is a sexually transmitted infection. This is caused by a spirochete, Treponema pallidum, okay, and characterized by primary, secondary, and tertiary stages. Incubation period is 9 to 90 days. These are all about cramming and remembering. Primary features are chancre, okay, so painless ulcer. This is an important information because sometimes they will be giving you a scenario where they will mention like either painless or painful ulcer, because you have to pay really good detailed attention to that particular area. So in terms of painful ulcer, the most common organism is herpes simplex virus, okay? Secondly, chancroid, not chancre. These two words are very much similarly sounding, okay? So let me just write it down. I will discuss about the genital ulcers a bit later on. Syphilis will cause chancre, and Haemophilus ducreyi will cause chancroid. Chancroid is painful, chancre is painless, okay? So I already previously I have mentioned so many times that RCP, what it will do is in the part 1 examination specifically, they will give similarly sounding words side by side to make you confused, okay? So you have to be very careful every detailed information you're reading about every infectious disease. So syphilis will cause painless chancre at the site of sexual contact, and that as this is a painless ulcer, this will also cause non-tender lymphadenopathy, okay? Then syphilis is usually latent in women. It's more prevalent in the male. Male tend to be more symptomatic compared to women population. All right. Next up is secondary features. Secondary features are fever, rash, arthralgia. Rash is quite important because these rash tend to appear on the palms and the sole, okay? And there is a specific rash which is known as the condylomata lata. So I don't have the picture of this at this moment. I've tried to look this up on the internet. Most of them look very much vulgar, and you can just look it up yourself. This is like basically painless, like wart-like projections. They kind of look like warts, but these are white and painless and projecting from the skin surface. And for example, if the primary syphilis took place, like for example in women, it has taken place in vagina or perianal area, or male, if it has taken place around the genital region, so the warts will be more prevalent in those particular sites, okay? These are non-discharging. This is non-ulcerating. These are just like projection, like wart-like projection. And buccal snail track ulcer, okay? And condylomata lata, yes. Tertiary feature, gamma, on the other hand, this is a deep ulcerative necrotic ulcer-looking type of lesion, okay? So they kind of very similar like squamous cell cancer. They look very horrible. And gamma lesions usually cause permanent disfigurement. And in the tertiary features, there are some cardiovascular and some neurological complications. So cardiovascular, it will be causing aortic aneurysm, aortic dissection. And in case of the neurological complication, neurosyphilis. Neurosyphilis is a very broad term. It can literally cause anything. In neurology section, we usually go by like multiple sclerosis, and neurosyphilis can present like anything and everything, okay? So it can, from the generalized tonic-clonic seizure to neurocognitive impairment, to dementia, to paralysis, everything can be explained by neurosyphilis. And tabes dorsalis is mainly, it particularly affects the cord. It's a cord pathology. It has a very wide variety of presentation, but tabes dorsalis can present in a mixed upper motor and lower motor neuron type of lesion in the legs, okay? And Argyll-Robertson pupil is also seen in neurosyphilis. Okay. So features of congenital syphilis, if I try to draw, like you can search this on the Google. Previously, back before the penicillin was discovered, syphilis was a very predominant type of infectious condition, okay? Especially it was seen among the wealthy, affluent male, and women who used to work as prostitutes in brothel. It was very commonly seen. And the babies who would be born from syphilis affected mother, they would be, there was a taboo regarding them. Like most of them would be, you know, like thrown, or they would be considered the child of sin, because their face would be such a characteristic feature. Like everybody would know that their mother probably had syphilis. Okay. So the blunted upper incisor teeth, that means like when the oral cavity is open, they kind of look like this. There's a gapping in between the incisor teeth, and they're like blunted compared to the other teeth, normal looking teeth. Okay. So blunted upper incisor teeth, keratitis, and deafness. This is known as Hutchinson triad. Hutchinson triad. And rest of these are like, as there is permanent disfigurement of the face, saddle nose, these are quite common as well, but do focus on the Hutchinson triad. Blunted upper incisor teeth, interstitial keratitis, and sensorineural deafness. Teeth, ear, and eye. Okay. So syphilis investigation. Treponema pallidum, this is usually, it's a very sensitive organism. So this is not, cannot be grown on regular, you know, artificial media. So that's why serological detection, these are more preferred. So back in our MBBS level, we have discussed about, or we have learned about TPHA and VDRL test, right? So tell me, like, let's see, Dr. Obhijit, you tell me which one is most specific, TPHA or VDRL? TPHA, okay. However, if you start the treatment for syphilis, okay, and you want to see whether the patient is responding to the treatment or not, or whether there is a relapse, so which one investigation would you like to consider? Yes, as this is positive even after treatment. So that's why in order to monitor, or in order to see the relapse, you should go for the VDRL test. That's why we should go for the VDRL and the TPHA test side by side. Because once the TPHA is positive, it will be positive for lifelong. Exactly. All right. So basically the serological test can be divided into the cardiolipin test and the treponemal specific antibody test, or the TPHA. Cardiolipin tester, syphilis infection leads to production of the non-specific antibodies that react to the cardiolipin, which is a type of antigen. And examples include VDRL and RPR, or the rapid plasma reagent test. Both of these are cardiolipin tests, okay? These are insensitive in the late syphilis, and they can become negative after treatment. So that's why they can be used to follow the prognosis or the relapse rate. And TPHA, this remains positive even after treatment. However, cardiolipin test can be sometimes falsely positive, and one of the commonest causes antiphospholipid syndrome, because in case of the antiphospholipid syndrome, antibodies are produced against the cardiolipin as well. So that's why, because of the cross-reactivity issue, this can be falsely interpreted as syphilis. But of course, syphilis presentation and antiphospholipid syndrome presentation will be very different. What happens in antiphospholipid syndrome? Can anybody tell me? Yes. Commonly, it's seen in women with repeated miscarriages, okay? Miscarriage. And it causes arterial and venous thromboembolism. And sometimes it can occur primarily, and sometimes it can occur secondarily in the background of connective tissue disorder like systemic lupus erythematosus. Okay. All right, syphilis management is IV benzyl penicillin, still the most important treatment. Alternative is doxycycline. I would say doxycycline is not really like only indicated for people who are allergic to penicillin. Apart from that, do try to remember penicillin. And Jarisch-Herxheimer reaction is basically like after injecting the first dose of penicillin, if the patient suffers from fever, rash, and tachycardia, that is known as the Jarisch-Herxheimer reaction. It's a very complicated Jewish name. So this is because of the, after the syphilis bacteria is killed, there is a huge release of endotoxin, which causes this reaction. Okay, leptospirosis, it's another spirochete infection, also known as Weil's disease. And for exam purpose, try to look for the clues like sewage worker, farmer, people who work in abattoir, basically in any contaminated water source. Okay. And this contamination takes place by the rat urine. And this is caused by the spirochete Leptospira interrogans. If you find it's very difficult to remember this scientific name, it's fine. Usually these questions will not come in the part 1 examination, but you have to remember the particular disease and the way it manifests, because the stem can be in a very similar manner and the culprit organism will be given in the as the option. Okay. So classically being spread by contact with infected rat urine. Wells disease should always be considered in high-risk patients with hepatorenal failure. So I have experienced 2 Wells disease patients. One was in my Upazila Health Complex, which is a primary healthcare center. And another one was, I have seen this kind of patient in the Dhaka Medical College back in our internship. So these kind of patients usually present like severe jaundice and subconjunctival hemorrhage and AKI, acute kidney injury, in the background of liver disease. So from the history, it seems a lot like this is a case of hepatorenal syndrome, a complication followed by chronic liver disease. However, after going for all the possible causes, like starting from the viral markers and the ultrasound of the liver and the fatty screening, like whether this is an alcoholic fatty liver disease, non-alcoholic fatty liver disease, ruling out the alcoholic fatty liver disease, all these common causes. And we have also done the different types of serological autoantibody to rule out the autoimmune causes and the metabolic causes. We were puzzled, like, okay, what was the reason? And then after taking just a very mere history, we came to know that the patient works in tannery and he has to stand in a very stagnant water, and while he is washing those like leather things, and he has to work in a very prolonged period of time where he's repeatedly in contact with this polluted water source. And that was our biggest clue. So serological antibody test was done against the leptospirosis, and it became positive. So it was a treatable condition. So you can see the features of fever, flu-like symptom, renal failure, jaundice, subconjunctival hemorrhage, headache. And management is similarly like the syphilis. Spirochete infection, the first line antibiotic is the benzyl penicillin. Okay. And the term Wills disease is sometimes reversed for the most severe manifestation of the leptospirosis. So once the disease becomes quite terminal, like there is jaundice, there is profuse subconjunctival hemorrhage, there is kidney shutdown, and like liver failure, that's when the term Wills disease is used. Otherwise, this is known as leptospirosis. Okay, Lyme disease, it's a very hot favorite for the MRCP Part 1 examination. So Lyme disease is basically caused by Borrelia burgdorferi. It's another spirochete infection. This is spread by ticks, tick-borne infection. So in the stem, try to look for if there is any mention of any tick bite, and if this is not mentioned directly, try to look for clues like whether this is mentioned, like the patient has traveled in the American forest, like Northeast America, usually in the forest regions. These ticks are more prevalent, and after coming back from like mountaineering or like backpacking, the scenarios will follow, like fever, joint pain, there is facial asymmetry, all these things. So that will be a clue. And another important clue is this characteristic rash. So this rash is I'm trying to draw it, let's see if I can. So this rash kind of looks like the bullseye. So there is like a central part, and then there is like another red peripheral rim. And this is central clearing, okay? There is nothing like the normal skin, and this is red, and there is the rim is red, okay? This is known as the erythema marginatum, annular lesion, okay? This is also known as the bullseye target lesion, occurs in 70% of the patients. So this is quite pathognomic. And late features are it can involve the heart, causing conduction block, arrhythmia, and it can cause some neurological complications as well, like cranial nerve palsy. This is a common cause of bilateral 7th cranial nerve palsy. Dr. Abhijit, did you attend the last neurology class? Okay. So I have mentioned like the differentials for unilateral and bilateral seventh cranial nerve palsy. Do you remember the other causes of bilateral? There is only three most important causes for bilateral seventh cranial nerve palsy. Can you mention one of them? Bilateral seventh cranial nerve palsy. Guillain-Barré syndrome. Guillain-Barré syndrome. Yes, Lyme's disease and sarcoidosis. Yes, very good. So neurological, it can cause cranial nerve palsy, particularly bilateral seventh. It's a common presentation, and it can also cause meningitis or meningoencephalitis. And joint pain is also, you'll see like fever, joint pain, rash, recent traveling history. There is a characteristic rash like, like central clearing and peripheral red rim, all these things. And now the patient is complaining of chest pain, breathing difficulty. You understand there is myocardium involvement. So the answer is Lyme's disease. Okay. So they might not ask you the, like organism in this type of stem. They might not ask you for the diagnosis as well. They might just give you like a question, which of the following intervention would you like to consider? Okay. So this is like you have to first read the stem, make the diagnosis, think of the differentials, and then go for the possible intervention. So here the treatment will be mainly antibiotic, and then rest of the supportive and the management care. Okay. So Lyme disease investigation is ELISA antibody, serological test here as well. All this, remember, all these spirochete infections, these are sensitive organisms. They are not easily grown in the normal culture. So there is no role of blood culture, urine culture, all these things, okay? So what you want to do is you should go for the serological antibody test. So for the syphilis, you go for the VDRL and TPHA. And for the leptospirosis or the Wheels disease, serological antibody could be ELISA, could be ICT test. And for the Lyme's disease, ELISA antibody. There is other serological test as well, like immunoblot assay for the Lyme's disease, and sometimes PCR can also be done, but this is like a last pool. So management is asymptomatic tick bite. Not all the tick bites need treatment. So if a patient tells you like he just recently came back from mountaining in the or hiking in the Alps in America, okay, so and now he feels like he's scared because he's heard of Lyme's disease. Now are you going to give him antibiotic right away? No, because not all the tick-borne bites are going to be Lyme's disease. So NHS does not give for asymptomatic tick bite treatment, okay? However, if the patient is symptomatic, like if there is only one symptom like fever or rash or joint pain, in that case there is indication of or role of antibiotic. So here I have mentioned like most of the spirochete treatment is benzyl penicillin. This is the only exception where the doxycycline is the first line treatment, okay? Amoxicillin is an alternative if the doxycycline is somewhat contraindicated, for example, pregnancy. Okay, that's all you need to know. Here in any of the spirochete infection, this Jarisch Herxheimer reaction can be present, but this is more prevalent in the syphilis treatment. Do not forget about doxycycline in Lyme's disease. I personally have a lot of difficulty in remembering treatment for Lyme's disease, because back in the time when I appeared for this exam, I didn't know better. So I messed up the Lyme's disease with Legionnaires, okay? And I answered, I think, erythromycin from the option. And then I became like, okay, no, actually the answer was doxycycline. Actually, doxycycline is given in the atypical pneumonia as well. Like think about this, any atypical pneumonia, doxycycline is also indicated. But in case of the Legionnaire's disease, macrolide antibiotic are more important than the doxycycline. And in Lyme's disease, which is a spirochete infection, doxycycline is more indicated. So sometimes you will be having your own confusion. Try to write that down, okay? Do not mess things. These are very easy questions. which antibiotic to give in which infection. These are very easy questions, trust me. So you don't want to mess that up. Normally, you would have been able to get that question right. This is a 10 on 10 question. Okay, so if you're having like similarly sounding condition and you're finding it difficult to remember which antibiotic for which condition, try to make a box like Lyme's disease, Legionnaire's disease, and another one is leptospirosis. Okay, and another one is Listeria monocytogenes. So there are 3 organisms that have L, starting with L. So try to make a box like which antibiotic to give for which condition. Yes, I understand. It's quite tricky. But you can, the only thing you can do is like you can help yourself. You can make like a box and try to write down the similar sounding condition one by another and try to write down like the confusing parts. You don't have to write like the whole box, including the what's the characteristic, what's the investigation, what's the treatment plan, not like that. Just try to write the summarized information, because that will save you just 2 to 3 hours before your exam takes place. Okay. All right, Listeria monocytogenes. Now we are done with the spirochetin for infection. We have discussed about the syphilis. We have discussed about Lyme's disease. We have discussed about the leptospirosis. Now Listeria, it's a bacterial infection. So it's a gram-positive bacillus which has the unusual ability to multiply at low temperature. So from only one sentence, you understand that here the important characteristic is the low temperature. So if in the stem it is mentioned that refrigerated unpasteurized dairy product, so it will give you a clue. Here you can see typically spread by the contaminated food, typically unpasteurized dairy products. So this is another clue, low temperature unpasteurized dairy products. So most of the when we are refrigerating food, we usually know that we are preserving the food. There is no chance that our food will be contaminated at such low temperature, because most of the bacteria or the germs, they need some optimum temperature to grow. Okay, so usually refrigeration is considered to be at a very good temperature to kill off this bacteria or not to let this bacteria grow. This is the only very bad bacteria which prefers the low temperature. So that's why pasteurization is very important. Can anybody tell me, still to this date in the world, only one type of people consume unpasteurized dairy product? This is actually a bit religious topic. However, only one group of people drink unpasteurized cow milk. The Amish people. Amish is it's a group of Jewish, it's a Jewish subgroup. Okay, they have like a very restricted. Amish culture is very different. I have lived in the northern part of London for a year, and I was in a very close proximity to the London Amish group, and I have seen personally their way of living. They usually do not, associate with people of other religion or other belief. They're very much, it sounds very bad, but they're kind of like a very cult kind of thing. Okay. They do not talk to Muslims or Christians or Orthodox Jews. They do not talk with the Hindus or, like people from other beliefs, people from other color, from other societies. They do not mingle with them. And they have separate school, separate housing societies, separate ponds, separate water facilities. Everything is separate for the Amish people. So if you, it's not like you cannot enter into their area. This is not restricted. So I only went there once, and I felt like this was just a village, like a very small village inside of this very busy, bustling London. It was a very different experience for me. Anyway, back to our topic. Okay, yeah. Listeria infection is particularly dangerous to unborn child, especially it can lead to miscarriage. Any infectious disease can cause these complications, but do not forget about the low temperature and unpasteurized dairy products. Okay, so what it can cause? It can cause fever, flu-like illness, diarrhea. Most commonly, it can cause pneumonia. Okay, and immunocompromised patients, it can also cause meningoencephalitis, ataxia, and seizures. Here you can see another important line. This is the tumbling motility on wet mound. Okay, So always try to look for something exceptional because that will help you in the exam. If you go for the blood culture and the CSF, and if you put it on the wet mount, there will be tumbling motility. So that will be very specific for Listeria monocytogenes. On the other hand, Vibrio cholerae, which is the responsible organism for cholera, on the wet mount, what it looks like, shooting star, right? But the tumbling motility is seen in the Listeria monocytogenes. This is sensitive to amoxicillin or ampicillin, so basically aka cell wall acting agent, and Listeria meningitis should be treated with intravenous, of course, broad spectrum IV. Like instead of going for the oral medication, you should go for the IV medication, and along with that you need better penetration, so gentamicin is given along with that, kind of like infective endocarditis management. Okay. Pregnant women are almost 20 times more likely to develop Listeria monocytogenes compared with the rest of the population because of their immune system is going a bit low. Fatal neonatal infection can occur both transplacentally and vertically. So basically, if a mother is infected during the childbearing age, the baby can be affected while inside the mother's womb or even during the birth, because it can pass both vertically and transplacentally. Diagnosis I've already mentioned, like CSF analysis and the blood culture. Treatment is with amoxicillin. Okay. Okay, I think I'm going to take the 5-minute break till the prayer is done. Then I'm going to start over with the gastroenteritis. Okay, so we're starting with the next topic, which is gastroenteritis. From third year to fifth year to internship, we have all gone through this topic over and over again, like especially loose motion 3 times or more than 3 times in the last 24 hours. That will be a clue for gastroenteritis. Now, traveler's diarrhea and travelers, in case of traveler's diarrhea, there will be a positive traveling history, trying the local food over there. Okay, and the incubation period is usually shorter or just coming back from the travel. That's when the tummy upset issues have started. And traveler's diarrhea will never cause any bloody or any or malabsorptive type of diarrhea. It will be most of the time this is watery diarrhea. There is one exception, like for example, if you travel to UK and now after 6 days coming back from UK, now you're experiencing, like flu-like illness and bloody diarrhea. In that case, in the UK, as the Campylobacter jejuni infection is widely prevalent, so that's when you can think of like, okay, this is a Campylobacter jejuni. All right. And in terms of, apart from that, most of the time traveler's diarrhea is watery. And for example, patient has gone in, like Bangladesh or India from the UK and tried the local food, and now the patient is experiencing crampy abdominal pain, alternative episodes of loose motion, and sometimes he is also noticing the blood in the loose motion, and there is another episode of constipation. And in the pulse examination, you see this is pulse is 45 per minute. What's the diagnosis? Tried the local food in the Asian area. No, I've mentioned the bloody diarrhea. Yes, alternative episodes of bloody diarrhea and constipation. And an important clue is pulse is 45 beats per minute. This is actually, yes, salmonella or enteric fever, or basically aka typhoid. This is a common manifestation. I personally suffered from typhoid, so I know all the symptoms you can have during typhoid. Like this is a very high grade fever and there is a relative bradycardia. So that means with every 1 degree Fahrenheit rise of your body temperature, the pulse rate should be increased by a factor of 10 beats per minute, okay? But in case of the enteric fever, only thing where the temperature is raised, but compared to that, the pulse is going low. I tried to monitor my pulse with an oximeter. I saw that my saturation was fine. It was 99 to 98. But however, my pulse was coming like I usually have tachycardia, okay? Normally, I'm tachycardic. 110 to 120 is my normal heart rate. But during that enteric fever phase, my heart rate dropped down to, like 50, 60. I could tell, okay, this is one of the characteristics that is happening to me. Very classical feature of enteric fever. Okay, coming back to gastroenteritis, food poisoning. So if you're seeing that the onset of the gastroenteritis or the loose motion has taken place in a very short period of time, you should only think of 3 differentials. One is Staph aureus, number 2 is Bacillus cereus, and number 3 is Clostridium perfringens, okay? And I will discuss about the incubation period a bit later on. E. coli, common among the travelers, watery stool, abdominal cramps and nausea. Giardiasis, this will be causing prolonged diarrhea, okay? And sometimes it can be so much prolonged that it can also cause malabsorption at the same time. Non-bloody diarrhea, however, giardiasis is not bloody. So cholera, of course, we have seen this kind of cholera patients in our Bangladesh so much. I'm not sure about the Indian population, but in Bangladesh, there is usually like circles of cholera outbreak, right? And the ICTTRB Institute gets filled with the cholera patients. So profuse watery diarrhea, that kind of resembles like rice water diarrhea. Like after you wash out the rice, then the fluid that you get, this kind of diarrhea is common in the cholera infection. This is caused by Vibrio cholerae. Severe dehydration, even sometimes acute kidney injury can take place in case of cholera infection. And also hypoglycemia can also occur in this cholera infection. Shigella, it's an invasive condition. That's why the bloody diarrhea will happen here along with the vomiting and abdominal pain. Not a very common scenario to come in MRCP part 1. Staphylococcus aureus is very, very, very important, okay? Very severe vomiting is more common than loose motion, and this has a very short incubation period within 1 to 6 hours. Campylobacter jejuni, flu-like prodrome is usually followed by crampy abdominal pain, fever and diarrhea, which can be bloody, and this is most prevalent organism causing gastroenteritis in UK. Contaminated cold cuts would be like, like we eat toppings on the pizza like salami, pastrami, like cold turkey, all these things. These are very common snack items or breakfast item in the UK. And this is found in, Campylobacter is found in these kind of cold cuts. Complication is followed by Campylobacter jejuni infection. There is a very common complication, Guillain-Barré syndrome, flaccid paralysis. Bacillus cereus, okay, two types of illness are seen, vomiting within 6 hours and diarrheal illness is occurring after 6 hours. And stereotypically like contaminated rice, like fried rice consumption. Amoebiasis, gradual onset, it has a long incubation period. Not only it causes bloody diarrhea, but it can also cause liver abscess. So incubation period is 1 to 6 hours in case of the Staphylococcus aureus and the Bacillus cereus, the vomiting predominant kind. But Bacillus cereus, if the question is like diarrhea predominant, okay, so it's usually not Bacillus cereus, because within 1 to 6 hours, if the diarrhea is taking place, it's usually Staphylococcus aureus. So 12 to 48 hours, answer is Salmonella, that is the enteric fever, and E. coli. 48 to 72 hour, Shigella and Campylobacter. Campylobacter has like an incubation period of 1 to 6 days, if you want to remember it in a very easier way. And more than 7 days, long incubation period, giardiasis and amoebiasis. E. coli apart from gastroenteritis, let's see how many are active right now. Dr. Anupam Bishwas, can you hear me?
Yes.
Okay, so apart from the gastroenteritis, what are the other infections that can be caused by E. coli infection? Or you have seen in maybe in your hospital during your ward round, internship? Female urinary tract infection, right?
Yes, it is very common.
Yes, it's very common because the female urethra lies in very close proximity to the anus, and there is, because of the shorter distance, the gut microbiota can easily travel to the urethra and cause this frequent infection in women. So another infection which can be notorious, and that is in the newborn babies, it can also cause meningitis. Okay, very difficult to treat, and the mortality is very high in the E. coli meningitis. Okay, serotypes. According to the antigen present on the cell surface, the serotype and the type of immune response it triggers, depending on that, this is mainly of 3 varieties. Okay, serotype. Dr. Kobi, you're quite late. No problem, take a seat. We are just discussing about infectious disease, and now we are talking about E. coli infection. Dr. Obhijit, help him a little bit, okay? Okay, so basically O antigen, this is present in the lipopolysaccharide layer, and K antigen, this is present in the capsule of the E. coli, and H antigen is present in the flagella, known as the flagellin, okay? And among these 3 like different antigens, K antigen or the capsule, this can cause neonatal meningitis, okay? And this particular strain, you can see, this particular strain like E. coli O, that means lipopolysaccharide layer, O 157 strain, and H is the flagella strain, okay, flagella 7 strain. This is particularly the responsible pathogen for hemolytic uremic syndrome. What happens in the hemolytic uremic syndrome is that there is hemolysis. The name itself suggests like hemolysis, so you can expect anemia and bleeding spots to appear. Uremic syndrome, that means that there is development of AKI, okay, acute kidney injury, and usually this acute kidney injury follows by a high-grade fever, bleeding spot, gradually becoming anemic, and repeated hemorrhagic loose motion. So the clinical picture will be something like this. The combination of fever is a plus minus, combination of hemolysis, so that means anemia and bleeding spot or rashes, and uremic syndrome. So uremic syndrome will follow by E. coli is preliminarily causing loose motion. So loose motion followed by AKI. This is the clinical triad of hemolytic uremic syndrome. And this is particularly spread by the contaminated ground beef. So maybe in the scenario, there might be mention of some eating of burger or something like that. Okay, so cholera, like just I previously mentioned, this can cause profuse watery diarrhea, like rice water diarrhea, dehydration, hypoglycemia, and AKI. I think there has been some mistake here. Try to write it down here. AKI is very common complication of cholera. So what's the management? ORS, oral rehydration. Sometimes the oral rehydration therapy is not enough. In that case, we have to go for the IV cholera saline, right? Dr. Kobir, have you ever managed any cholera patient?
Yes.
In your internship, have you seen one cholera patient? What's the usual antibiotic that you give? Okay, Cipro. In your hospital? Yes, and along with that, which antibiotic? In, I think only in Dhaka Medical College they practice this. They give the initial dose of azithromycin, okay, in loading dose, IV or a cholera saline, and then start with the Cipro. I know that there is no justification for going through, like both antibiotic at the same time, because you can either go for the azithromycin loading dose or you can go for the ciprofloxacin. However, in Dhaka Medical College, they don't want to take risk because all the terminally ill patients are coming over here. So that's why they start with the first loading dose and go for the gradual ciprofloxacin. Doxycycline is another alternative here. Okay. Salmonella. Salmonella is the organism which nearly killed me. I literally suffered a lot because of this enteric fever. Initially, at that time I was a 5th year medical student, so I was going through brainstorming. Maybe I have the meningitis. I was so upset in the first few days because the fever is very, very high. It never goes low, okay? Like even if you take 2 paracetamols 3 times a day after meal, the fever will not subside. And you're always sweating, you're feeling drowsy, you're feeling body ache throughout your body. And I confused my body ache with the, neck stiffness, because that I thought that this was probably meningitis. And along with that, your appetite goes really low. You don't feel like eating anything. And that relative bradycardia, which I've mentioned previously, luckily I did not have any spots or something like that. But for some weird reason, I lost a lot of my hair. I don't know, like it's different for a lot of people. I lost a lot of hair during my enteric fever infection. So they're aerobic. These are aerobic gram-negative rods, which are not normally present in the commensal in the gut. This is an important information. Sometimes it can be coming in the true-false statement, because E. coli infection is a normal commensal in the gut, okay? But Salmonella never is. And all this gastroenteritis causative organism, most of them are gram-negative rod, okay? Typhoid, paratyphoid are caused by Salmonella typhi and Salmonella paratyphi. Paratyphi is further into different subgroup A, B, C, and these are often termed as enteric fever, producing systemic symptoms like headache, fever, arthralgia. Okay, relative bradycardia, this is very important. Abdominal pain, distension, constipation. I did not have diarrhea, I did not have any abdominal problem. I had the pain though. And rose spots present on the tongue in 40% of the patients, and more common in the paratyphoid infection rather than the typhoid infection. Possible complication. This is quite important to remember, okay? In sickle cell disease, the Salmonella typhi can cause osteomyelitis. And gastrointestinal bleeding, it can cause perforation, bleeding, cholecystitis, okay? Meningitis and chronic carriage. That is, this Salmonella is stored in the gallbladder, and in 1% cases, if not treated well, then it can relapse again, and that's why these kind of patients should go for cholecystectomy. Okay, Shigella, just remember that this causes bloody diarrhea and abdominal pain, treated with ciprofloxacin. Campylobacter, this is important. It's a gram-negative bacillus or gram-negative rod, commonest bacterial cause of infectious intestinal disease or commonest bacterial cause of gastroenteritis in the UK. Transmitted by the fecal-oral route, incubation period of 1 to 6 days. This is very important. Okay, incubation period for Campylobacter jejuni. This is try to write it down. Present in the cold cut meat, like salami, pastrami, all this thing, cold cut. Just write it down like by this side. Okay, so what are the features of Campylobacter jejuni? Prodromal illness is more common, so maybe low-grade fever. This is not causing high-grade fever, unlike typhoid, okay? So it usually causes low-grade fever, malaise, some body ache and headache, and diarrhea is bloody diarrhea. Usually self-limiting, and if this is not a severe case, they do not usually give the antibiotic. And this is the only gastroenteritis where the initial treatment is with first line antibiotic is macrolide, clarithromycin, okay? And rest of the other gastroenteritis first line treatment is ciprofloxacin, okay? Complication, Guillain-Barré syndrome and Ritter syndrome, also septicemia, endocarditis, basically it's like disseminated infection can also take place. But do not forget about the GBS and the Ritter syndrome as a complication of Campylobacter jejuni. Amoebiasis is caused by protozoa. It's a protozoal infection, Entamoeba histolytica, transmitted by the fecal-oral route, okay? And infection can be asymptomatic or sometimes mild diarrhea or even severe amoebic dysentery, which is crampy abdominal pain. Here, rather than the diarrhea, pain is more prominent in the dysentery, okay? And rectal cramps, this is also more prominent in the dysentery, amoebic dysentery. Along with that, there may be, in the severe cases, there might be invasion of the intestine causing bloody diarrhea. Amoebiasis also causes liver and colonic abscess. Okay, amoebic dysentery, profuse bloody diarrhea. Stool microscopy may show the trophozoites. Cyst is not present. Why? Because trophozoites will be present, the trophozoites invade the intestine. That's why you can get in the stool microscopy, you'll be getting the trophozoite, but cyst is dormant in the liver, okay? Treatment is with metronidazole. Metronidazole in our hospital, 2/3 of the metronidazole bottle is given as a loading dose, and then according to the one bottle of metronidazole 3 times a day. Amoebic liver abscess might be presented with right hypochondric region pain, fever, tenderness, and single mass. Sometimes it can also present like that. You should never palpate. That's why while palpating for the tender hepatomegaly, be very gentle, because if it's a congestive cardiac failure, that's fine. It will not cause any further complication. But if this is a case of amoebic liver abscess, the abscess will be ruptured and the infection will be seedling out into the peritoneum. Okay, so tetanus is caused by it's a toxin mediated infection. So this toxin is the tetanus plasmid exotoxin. This is important to remember. Released from the Clostridium tetani. Tetany spores are present in the soil. So that's why in the rural area, if you're walking in a barefoot and now you're having a wound, like you have stepped on something like a rusty metal or something. So in that case, we have frequently dealt with these kind of patients. They're taken immediately to the primary healthcare centers, and we try to clean the wound as soon as possible, and we do not take any risk. We give the patient active passive immunization, okay? Because once you are in the toxin mediated condition, what happens is there is no cure. There is no antibiotic that can cure this condition, because this is a toxin mediated, not the bacteria itself. So once the tetany toxin binds to the receptor and a period of consequences take place, it's very difficult to control that, and usually associated with a very high mortality rate. So it's very important to go for the active passive immunization in these cases. Here in tetany and botulism, if you go for side by side, I will discuss about botulism in a bit. I just want you to focus on these two things, tetany and botulism. What tetany does is it prevents the release of GABA. GABA is an inhibitory neurotransmitter. So when the inhibitory neurotransmitter is inhibited, what will happen? Painful, excitable contractions in the muscle. And in case of the botulism, acetylcholine is prevented. Acetylcholine is an excitatory neurotransmitter. So when the excitatory neurotransmitter is blocked, then the body will be flaccid. Okay, flaccid paralysis will take place. Okay. In the true false statement, they might switch these. Okay, so the GABA can be switched to acetylcholine, and the acetylcholine can be switched to GABA for botulism. Be careful. What are the features? Prodromal fever, lethargy, headache. Important ones are trismus or locked jaw, very painful. The jaw is locked, and this is a very painful condition. Rhizus sardonicus, which is also known as the devil's smile. Opisthotonus, that is arched back and neck is hyperextended. Spasm, painful spasm, dysphagia. Okay, this can also have a very similar feature in rabies. Rabies will have a very similar feature like this. Management is basically supportive therapy. Ventilatory support might be needed. Muscle relaxant, intramuscular human tetanus immunoglobulin, which is the passive immunization for high risk wound. However, if a person's tetanus vaccination cannot be found, then do not wait for the active vaccine. Go for simultaneous active and passive immunization. Now, metronidazole is now preferred as this has a more anaerobic tendency. That's why metronidazole is preferred than benzyl penicillin as the antibiotic of choice. Tetanus vaccine is given in the UK as part of the routine immunization, scheduled as 2 months, 3 months, 4 months, 5 years, 18 years. Okay, there is usually 5 doses of tetanus containing vaccine, and I think I previously mentioned this. This is just saying that if this is a high risk wound, go for the passive immunoglobulin. If the record of the vaccine is not complete, then go for both active and passive immunization. So far, any question? Okay, let's see how many participants. Dr. Neha Singh. Dr. Neha Singh, can you hear me? Okay, Dr. Elizabeth Sarkar.
Yes, please.
Okay, so can you tell me the treatment for Lyme's disease?
Yes. Doxycycline.
Doxycycline. Okay, good. Dr. Abhijit, do you agree with her? Treatment for Lyme's disease? Doxycycline. Okay, good. And Dr. Kobir, as you have just started with us, so what are the 2 most complications that is related with the cholera? AKI. Okay, yes, and dehydration, electrolyte imbalance, AKI, hypoglycemia. These are the complications. Okay, all right. And let's see. Okay, traveler's diarrhea, most common organism, which one? E. coli, very good. And if you get a triad of hemolysis, AKI, and diarrhea, which one is the culprit strain? It's 7. Okay, very good. E. coli, 0. It's not 0, it's actually O. O is the antigen for lipopolysaccharide layer. So O 157 and H 7. Very good. Okay. So, all right, and let's see another candidate, Dr. Ahsanul Haq. Can you hear me? Dr. Ahsanul Haq? Okay, Dr. Onupam Biswas?
Yes, Harry.
Yes. Can you tell me the treatment for amoebic dysentery?
Amoebic dysentery. It is
Yes.
metronidazole.
Metronidazole, very good. And apart from the amoebic dysentery or the intestinal amoebiasis, what other organ can be affected by amoeba? What other organ? Dr. Kobir, which other organ can be affected by entamoeba histolytica apart from the intestine? Liver, very good. So what does it cause in the liver? Liver abscess. Okay, yes, very good. Okay, so moving on. If you have any questions for me so far, what I have discussed about the gastroenteritis, I've discussed about the spirochete infection and sexually transmitted infection, some of that. If you have any questions, please let me know. I feel like it gets a little bit confusing with the different types of organism and the treatment options, but do try to pay attention, okay? All right, so what's the treatment for tetanus? Dr. Abhijit? Sorry? Immunization, okay. So the patient has already been having tetanus. Now, which antibiotic would you like to go for? Metronidazole, okay, why? Anaerobic tendency, okay, good. All right. Botulism caused by Clostridium botulinum. It's a gram-positive anaerobic bacillus. Okay, there are 7 serotypes. A to G produces the botulinum toxin, which is a neurotoxin and irreversibly blocks the release of acetylcholine, which is an excitatory neurotransmitter, and thereby it causes flaccid paralysis or flaccid paraplegia. May result from eating contaminated food like tinned food. A lot of our foods are actually tinned. For example, we eat tinned mushroom, tinned corns, tinned like tuna fish, sardines, right? So sometimes if this is contaminated with botulism, it can be very serious. So it's always good to heat, at least using the microwave before eating the canned food. Okay. Neurotoxins often affects the bulbar muscles. Actually, neurotoxin will have a very wide variety of action because acetylcholine receptors are present throughout the different muscles. Okay, so especially if it like binds with the skeletal muscle acetylcholine receptor, it will cause flaccid paralysis. If it binds to the muscles of swallowing, it will cause bulbar paralysis. If it binds to the muscles present in the eye, like extraocular muscle, it will cause ophthalmoplegia. Okay, so patients usually fully conscious with there is no sensory impairment, okay, because the sensory fibers are not affected by the botulism, rather the motor receptors, the acetylcholine receptor present in the motor or the muscle fibers, that is affected, right? So flaccid paralysis, diplopia, ataxia, bulbar palsy, all these things can happen. Ataxia here occurs because of the muscle weakness, not because of the cerebellum involvement. Be very careful. Treatment with antitoxin is only effective if given early. Once the toxin has bound its actions, it cannot be reversed. However, botulinum toxin can sometimes be useful in conditions like, celebrities go for this. What is it called? Botox injection. What does the Botox injection do? It causes permanent tightening, disappearance of the wrinkling, okay? It has like a reversal effect of what I have discussed. In the pathognomic condition, it causes flaccid paralysis. But when you use it in the therapeutic dose, what will it cause? It will cause, not actually spastic, like it will prevent the further sagging, okay? So like it disappears the wrinkles in the face, and this is known as, I think, crow's feet. Here the 3 triangular stretch marks, this is known as the crow's feet. A lot of celebrities inject here to disappear all these wrinkles, like here. And not only that, some painful condition like torticollis, which is painful neck spasm, also used by the botulism toxin. Blepharospasm, this is repeated blinking, okay? and involuntary repeated blinking of the levator-palpebral muscle. This is known as the blepharospasm. Strabismus. All these conditions can be treated with the help of botulinum toxin. Okay. So what is the treatment for botulism? Antitoxin if used early. Okay. Clostridium difficile, this is a very important, not only MRCP part 1, but for PACES topic. This particular topic is important for both part 1, part 2 written and PACES examination, okay? So first of all, this is a gram-positive rod often encountered in hospital practice. So it's a hospital-acquired infection, first of all. Secondly, imagine this is usually present in a normal commensal. This is a normal commensal in the gut, okay? Just like E. coli. However, once you're injected with a broad spectrum antibiotic, what it does is it kills off the naturally occurring flora in the gut. That's when the Clostridium difficile takes the upper hand. This is an opportunistic infection, the Clostridium difficile infection, okay? Normally in healthy individual, it will never cause loose motion. But in immunocompromised patients, especially after giving certain types of antibiotic, there is shifting of the natural gut microbiota, thereby taking the upper hand and causing loose motion. This is known as the pseudomembranous colitis. All right, so the important drugs are, you can write it down, which antibiotics are responsible. Clarithromycin, clindamycin is mentioned here. Apart from that, write down clarithromycin, cephalosporin, especially clindamycin and clarithromycin, never forget about this. So ceftriaxone, yes. So features are diarrhea, abdominal pain, fever. It can also cause bloody diarrhea sometimes, okay? Raised WBC count is characteristic, and if severe, toxic megacolon can develop. From the pseudomembranous colitis, it can also cause toxic megacolon. Diagnosis is made by detecting the Clostridium difficile toxin, known as the CDT, in the stool. Management is first-line therapy is oral. Here, they might confuse you with giving you options like IV metronidazole, okay? But do not go for that trick, because treatment is always oral in case of the Clostridium difficile infection. We will discuss about the life-threatening a bit later on, okay? Why it is important? Because this is a colonic infection. In the colonic infection, usually the oral antibiotics will be more effective rather than the IV antibiotic. Why? Because the infection is transmitted through the fecal route present in the colon. So you want to go for direct action. You either go for the oral route or the parectal route. Parectal route is not available. So which route is available? Oral route. Okay. Oral metronidazole. If severe, not responding to metronidazole, then oral vancomycin can be used. For life-threatening infection, a combination of oral vancomycin plus IV metronidazole can be used. Okay. This is an exception. Like in the severe life-threatening condition, you give the oral vancomycin at the same time. Along with that, to prevent the systemic release, you go for the IV metronidazole at the same time. And what are the risk factors? Not just the broad spectrum antibiotics, sometimes use of the proton pump inhibitor and the H2 receptor antagonists, such as cimetidine, or like proton pump inhibitor. It's a rare, but in the first generation PPI, it can cause like this. For example, the omeprazole, okay? And contact with other person infected with C. diff infection. So after being diagnosed with Clostridium difficile, what will the hospital do? They will immediately shift the patient to the isolation room or the side room. So the patient is no longer in contact with the healthy individual, because it can be easily cross-contaminating the other normal healthy individuals. So isolation is very important as part of the treatment protocol. As a general rule of thumb, I think that giving proton pump inhibitor in any gastroenteritis is not a good idea, because there is always complication of diarrhea in any of this proton pump inhibitor, okay? Unless the patient is suffering from extensive peptic ulcer disease, or the medication you are giving the patient has potential threat to cause severe PUD, it's better not to give any type of antacid or PPI in a diarrhea patient, okay? But in routinely, we do practice like giving saline, proton pump inhibitor, metronidazole, and loperamide, all these like cocktail therapy. It's a very bad practice. Okay, cat scratch disease, it's only like 3 to 4 line, but each of these lines are very important because in UK this is quite common because a lot of UK people will have cats and dogs as their pets. So this is a common thing to experience over there. So important is the organism. It's a gram-negative rod, Bartonella henselae. Fever, history of a cat scratch. Of course, in order to diagnose the cat scratch disease, there will be some sort of cat scratch in the previously. Regional lymphadenopathy, the lymph nodes are usually like a tennis ball, okay? The lymph nodes become so much swollen, it resembles like a tennis ball over there. And headache, malaise, all these are features. Here, this is very easy to get the diagnosis of cat scratch disease, right? Because there will be like a cat bite or cat scratch, and then like regional lymphadenopathy, you will get the diagnosis. Here, they will give you which of the following organism is responsible for this condition, okay? Bartonella henselae. Now, the pet is already immunized, right? So there's no need, just go for the antibiotic as usual. Like human bite, compared to all the, which you wouldn't believe, like among all the animal bite, human bite is actually potentially fatal. I have just seen a post in platform, I think, one of the doctor's kid was bitten by another kid and he was asking for some form of information, and there is, to my utter surprise, there is actually a guideline in treating conditions like human bite, okay? Coamoxiclav is the first line treatment, and cat scratch disease, this is the same, coamoxiclav. Okay, here I was in the beginning of my lecture, I was talking about the ulcers, okay, genital ulcers. So genital ulcers most often caused by the herpes simplex virus type 2, cold sore, usually due to the HSV type 1. Just remember herpes simplex virus, okay? And primary attacks are often severe, associated with, sometimes apart from the painful ulcer, there might be features of fever as well. You should try to remember the causes of genital ulcer, like painful versus painless ulcer. Chancre, which is caused by syphilis, painful or painless? Painless, very good. Chancroid, caused by Haemophilus ducrei, painful or painless? Painful. These are similarly sounding condition, which I previously mentioned. Okay, and lymphogranuloma venereum, it's a bit unlikely or unusual, like I will tell you how. Because the ulcer is usually painless, but the lymphadenopathy is usually painful. In case of the LGV, which is caused by the chlamydia trachomatis, the ulcer is usually painless, but the lymph node is usually tender. And in the stage 3, there is evidence of proctocolitis. So there is some other causes of genital ulcer, not that important for infectious disease, like Beckett's disease. It's an autoimmune condition where there is recurrent oral sore and genital sore. And this is a prothrombotic condition as well. There is recurrent episodes of blood clot formation. That's why these kind of patients might have bloody diarrhea, stroke episodes, or, you know, like ischemic pain, chest pain, all these complications. Carcinoma, more or less, this is very rare. Granuloma inguinale, not really important. Just try to remember these particular ones, okay? Chancre, chancroid, and herpes simplex, which is painful, and LGV. Ulcer is painless, but the lymph node is painful. Okay. Chlamydia. This is actually, I cannot stress how much important this, like I understand we did not particularly pay much attention to chlamydia and all these infectious conditions back in our 5th year, but chlamydia is so much common in the UK that I will tell you how they go for the screening in the UK after finishing this topic. So chlamydia is the most prevalent sexually transmitted infection in the UK, and this is caused by chlamydia trachomatis, okay? Chlamydia trachomatis in the long run can also cause lymphogranuloma venereum, LGV, okay? It's an obligate intracellular pathogen. Approximately 1 in 10 young women in the UK have chlamydia. Do you understand the severity of this condition? 1 in 10 women, that is, it's very, very prevalent. Incubation period is around 7 to 21 days, although it should be remembered a large percentage of cases are asymptomatic, mostly women. Women mostly asymptomatic for chlamydia infection. Men usually have the symptoms, okay? Women can have all this sexually transmitted infection. Common characteristic is they are dysuria, urethritis, vaginitis, cervicitis, okay? And potential complications are think of it like an ascending structure. So from the urethra, there is epididymis in case of male. In case of women, there is the other like pelvic organs, right? Like the ovaries and the fallopian tube and the salpinx, whatever. So potential complication like epididymitis in case of male, pelvic inflammatory disease or the PID in case of female, endometritis, increased risk incidence of ectopic pregnancy, infertility, reactive arthritis, very, very important, okay? One of the common, what is reactive arthritis? In rheumatology, I have discussed this. Usually. Good, you're going there. It's a Ritter syndrome, right? Can't see, can't pee, can't bend the knee. Okay, so that's red eye, can't pee, that means like painful dysuria, basically dysuria or urethral discharge. Can bend the knee, that means usually monoarticular joint, or sometimes oligoarthritis can also happen. This is a subgroup of the reactive arthritis, but it's very good that you guys remember that. Perihepatitis, which is the Fitzhugh-Curtis syndrome, okay? It's a bit difficult name. Just remember, like it's a form of ascending infection related to the pelvic or the genital infection. Investigation, NAT test or the PCR test, okay? Nucleic acid amplification test is done to detect chlamydia. Investigation of choice. Screening. Screening program is open to all men and women who are sexually active, age ranging from 15 to 24. Management, doxy, okay? First 3 times, doxycycline. And then remember azithromycin. Why compared to doxycycline, azithromycin is usually better? Because azithromycin is only a single loading dose, okay? But doxycycline, you should complete the 100 milligram of 7-day dose. But in option, if comes like which one would you prefer, you can go for the azithromycin because this is only a single dose. But usually they will not give scenarios like this. It's usually the doxy, okay? 7-day course of doxycycline or azithromycin single dose. If pregnant, erythromycin or amoxicillin can be used because doxycycline is contraindicated in pregnancy, okay? And azithromycin, it has some side effects on the fetus as well. So you can go for either erythromycin or cell wall acting agent, amoxicillin here. And considering azithromycin during pregnancy, it's a specialist decision, okay, not yours. Patient diagnosed with chlamydia should be offered a choice of provider for initial partner notification. So what does that mean? So any patients, like I've already mentioned, chlamydia is a very prevalent sexually transmitted infection in the UK. So for example, a woman has been diagnosed with chlamydia infection. What will happen? They will immediately refer the patient to the GUM clinic, which is known as the genitourinary medicine clinic. And after giving her treatment, like for example, this woman is not pregnant, so we give the 7-day course of doxycycline, okay? So we will ask her, like, whom have you been in contact with in the last 4 weeks, as the patient is symptomatic. So in the last 4 weeks, whom you have been in contact with. And if it was incidentally diagnosed, like for example, this woman has no sign symptoms, but for a regular, like routine, inspection, this was picked up that she has become tested positive for the chlamydia. In that case, we will tell her to notify any of the guys she has met in the last 6 months, okay? Do you understand? If this is a symptomatic case, we will go for the partner notification within last 4 weeks, that's all. But if it's a asymptomatic or latent case, in that case, we have to go a bit broader. So in the last 6 months, whom you have been in contact with, we will try to go for them. And here, what's the good thing is that NHS always keeps the patient confidentiality. So if that woman or the man who is affected with the chlamydia tells the NHS their partner's name. Like, okay, I have been with like Luke, Andrew, whatever age, like this. What they will do is they will send a testing kit, okay, by contacting with their GP. And at the same time, they will also give one single dose of azithromycin. And that person will be able to collect it. Like he or she doesn't even need to know whom that person has got it from, okay? It will remain confidential, but they will send the testing kit and the medication using the postal code, okay? So you see, like, this is how the NHS system works. It's very sophisticated, to be honest. I have ordered like multiple kits of COVID-19 testing kit, and I have received those things via the postal service. It's very good. Like, I didn't even have to go to the hospital. I didn't have to go to any of the healthcare workers. They just deliver the testing kit along with instruction, and you can test it for yourself. And then they will give a certain package. You can put it there and then seal it and drop it down in the postal area, and they will collect it, and then they will, like, give you the result. Everything is without any contact whatsoever. So I think for treatment of chlamydia, what will be the antibiotic then? Doxycycline. But if in the in the option there is mention of doxycycline and azithromycin, which one would you prefer? Azithromycin. Why? Single dose. Yes. Okay. So for any question from chlamydia, it's very important. Okay, gonorrhea is caused by gram-negative Diplococcus, Neisseria gonorrhoeae. Neisseria gonorrhoeae, apart from causing infection, like genital infection, can Neisseria gonorrhoeae cause something even more devastating? Neisseria gonorrhoeae, apart from causing sexually transmitted infection or STI, meningitis, yes, it can cause meningitis as well. Okay, acute infection can occur in any mucous membrane surface, typically genitourinary, but can also involve the rectum and the pharynx. The incubation period of gonorrhea is usually 2 to 5 days, so it's a relatively less compared to chlamydia. Chlamydia is 1 to 3 weeks, right? 7 to 21 days, basically 1 to 3 weeks. And gonorrhea infection incubation period is a bit smaller, 2 to 5 days. Gonorrhea will be causing more discharge compared to chlamydia. Chlamydia usually causes itchiness, uneasiness, burning sensation during peeing, and gonorrhea usually causes purulent discharge. Okay. Rectal and pharyngeal infection is also is usually asymptomatic. Okay. Local infection. Okay, recurrent infection, what it can do is, from the epididymitis, recurrent infection can also cause urethral stricture and thereby causing infertility in the long run. And it can also cause salpingitis in case of female, thereby causing stricture formation over there as well. So it's also another cause of subfertility in case of female. Why in male this is a cause of infertility, but in case of female subfertility? Why? It's basic anatomy, because male have one epididymis, okay, for ejaculation purpose, yes, and for women there is 2 fallopian tubes, right? Okay. All right, management is no need to remember this, just go through this. Management is ceftriaxone 500 milligram intramuscular as a single dose with azithromycin 1 gram oral as a single dose, because this azithromycin is given for coverage of the chlamydia as well. Okay, so for gonorrhea infection, once a patient is tested positive for gonorrhea, as chlamydia is so much prevalent, they do not take any risk whatsoever. They treat along with that chlamydia as well, like intramuscular ceftriaxone along with that loading dose of azithromycin. Okay. No need to remember ciprofloxacin. Okay, ciprofloxacin is no longer used in gonorrhea. Disseminated gonococcal infection, DGI, and gonococcal arthritis may also occur with the gonococcal infection, being the most common cause of septic arthritis in young adults. Okay, in young adult male or female, septic arthritis, commonest cause is gonococcus. pathophysiology, but in case of, imagine in a diabetic patient, in an elderly, there was certain type of procedure that was done, and now the patient presents with septic arthritis. What's the commonest organism? Staphylococcus aureus, yes. And in the younger patient, gonococcus, Neisseria gonorrhoeae is the commonest cause, especially sexually active individuals. Okay, pathophysiology of the disseminated gonococcal infection is not fully understood, but it is thought to be due to hematogenous spread from the mucosal infection. Initially, there may be a triad of symptom. You should remember this: tenosynovitis, migratory polyarthritis, and dermatitis. So, disseminated gonococcal infection or gonococcal arthritis, there is a triad of three things, that is inflammation of the synovium, that is tenosynovitis, migratory polyarthritis, and dermatitis. Keratoderma blenorhizicum. Is it getting a bit difficult? Okay. So for treatment of chlamydia, Dr. Kobir? Or? Okay, very good. And treatment of gonorrhea? Yes? Yes, with that? Azithromycin, yes, good. Okay, pelvic inflammatory disease, I'm not going to go through details. It's very common, the causative organism is chlamydia, Neisseria gonorrhoeae, mycoplasma, and treatment is basically like in our country, we follow the pattern like Cipro and Metro combination for the pelvic inflammatory disease. In the NHS, they usually go for any of the fluoroquinolone along with that metronidazole, okay, to cover the bacterial vaginosis and the trichomoniasis at the same time. Okay, we'll just go through the vaginal discharge now. So commonest cause of vaginal discharge is, it can be physiological. Why? Because a lot of the time it can depend on the temperature, humidity, and the type of undergarment that is used. And common causes are like fungal infection, candida, which is more common in immunosuppressed condition like diabetic women. It can happen. Trichomonas vaginalis, this is a sexually transmitted infection. Bacterial vaginosis, this is not an STI, okay? Among these three things, only Trichomonas vaginalis is sexually transmitted. But candida or the bacterial vaginosis, these are not sexually transmitted. Less common cause for the vaginal discharge, okay? Chlamydia and the gonorrhea, these are actually less common. And apart from that, ectropion, foreign body, cervical malignancy, whatever, not very important. We will discuss about candida versus trichomonas versus bacterial vaginosis. The characteristic of this kind of infection. There is, I think, a diagram. Yes, this one. So for candida, it's very easy to detect because there will be very thick cottage cheese-like discharge. The discharge is very thick and itching is more predominant complaint. Trichomonas vaginalis, it causes strawberry cervix, okay? Apart from that, itching is also very predominant in the Trichomonas vaginalis infection. Bacterial vaginosis causes fishy odor or fishy discharge, and the discharge is usually thin, watery gray, whitish gray. Okay, Trichomonas vaginalis, this is a protozoal infection and sexually transmitted infection. This is important. And here, I think you should go through this. They do have the bacterial vaginosis and the trichomoniasis. They have a common property like offensive discharge seen in both of these conditions. Vaginal pH is more than 4.5 or alkaline. Normally, vaginal pH is acidic, less than 3.5, okay, because of the presence of lactobacilli. But in both bacterial and the trichomonas vaginosis, vaginal pH becomes high. And treatment for both of these conditions is metronidazole. For candida, fungal, antifungal ointments. These are more commonly given, right? Okay. For bacterial vaginosis, the discharge is thin, watery, gray, fishy odor. And trichomonas, there is itchiness is more common, vulvovaginitis. This is usually frothy and yellow-green discharge, strawberry cervix. And in the wet mount preparation, it shows motile trophozoites. Treatment for both of these conditions, bacterial and trichomoniasis. Which one? Metronidazole. So sometimes it becomes very difficult to understand whether this person is having, without doing any local examination, because in our country there is so many taboo and stigma going on. And also in the outdoor, in primary healthcare setting, I had to see like 150 patients within 3 hours. It becomes very difficult to go for each and every local examination. Okay. And so what I usually used to go for is, like, I would tell them to go for personal hygiene maintain. You should wash your vagina frequently, try to keep it clean, try to wear the clean underwear, and sometimes use the salt in lukewarm water and then clear the area. Apart from that, I would give like an antifungal ointment, and along with that oral tablet metronidazole. Okay, that will be enough to treat any of these infections she might be having. Okay. Urinary tract infection, I think if you guys go through this just once, it will be easier. However, do remember, like, the lower urinary tract infection in uncomplicated non-pregnant women, duration is for 3 days. Typically 3 days. In our country, this is never followed. We usually go for antibiotic prescription of minimum 7 to 10 days, and this is complicated, then we go for 14 days. Okay, but in UK, they go for 3 days course of nitrofurantoin. But if this is a case of complicated, in that case, they go for 7 days. Okay. Acute pyelonephritis treatment is broad spectrum cephalosporin or quinolone. But before that, never go for this broad spectrum antibiotic in the initial stage. Go for either amoxicillin, nitrofurantoin, thimerethoprim, all this medication. Okay. Any antifungal, A1 ointment, there is like basically fluconazole, itraconazole, these type of antifungal can be given. But it's best not to go for any steroid containing preparation. Okay. Okay, so nematodes, highlight these words like larva migrans and larva currents, because I think I had one question from the Strongyloids starcularis in my part 1 examination. Larva currents, that is, I will try to draw a diagram here. Strongyloids starcularis, this is acquired percutaneously. That means walking barefoot. This is a risk factor, okay? And it causes pruritus and larva currents. So for example, you're walking barefoot or working in the garden, and you have some cracks in your heel. This is common, right? Heel crack. So if this is a prevalent area, then this Strongyloids starcularis can enter through this breach in the skin, and it initially does not cause any pruritus. However, once it travels through the skin, it causes a significant or characteristic skin lesion. This is known as the larva currents. Okay, this is visible from the outside, and along this area it will have like a fern pattern, like itchiness. Okay. And once it has traveled through the system, like in the tummy, it can cause abdominal pain, diarrhea, pneumonitis, may cause septicemia as well, especially not itself, but because through this stream, there is also introduction of the bacteria, so thereby causing the septicemia, and eosinophilia is seen. Management for the trematode is thibendazole, albendazole. Remember the albendazole. Strongyloids starcularis, it's an important topic for MRCP part 1. Okay, they do somewhat like this topic. So this is a human parasitic nematode worm present in the soil, gain access to the body by penetrating the skin. Infection with the Strongyloids starcularis causes strongyloidiasis. Diarrhea, abdominal pain, papillovesicular lesion where the skin has been penetrated by the infective larvae, that is sole of feet or buttocks. Larva currents, pruritic, linear and urticarial rash. Okay, if the larva migrate to the lungs, a pneumonitis similar to the Loeffler syndrome can be triggered. Okay, Loeffler syndrome is one of the causes of pulmonary eosinophilia. Treatment is ivermectin and albendazole. From the tapeworm, okay, tapeworm is not really that important. You can just give a read when you are home. I'm going to go through the schistosomiasis. Okay, so for any questions, like from what I've discussed regarding the vaginal discharge or the sexually transmitted ulcer, the genital ulcer, and I've also gone through the strongylosis starkeralis. Any questions from there? Okay, let's try to go through a little bit. Okay, so tell me, cottage cheese like discharge causing itchiness, which organism you're thinking? Candida, okay. All right, and fishy odor and thin watery type of gray, whitish gray discharge. And there is profuse itchiness as well. Which one? No, fishy odor. This is characteristic for the bacterial vaginosis caused by Gardnerella. Okay. Treatment for bacterial vaginosis? Metronidazole. Okay, very good. And let's see. Larva currents is seen in which type of condition? Strongylosis, right. And here, Dr. Anupam Vishwas, can you hear me?
Yes.
Okay, so what's the treatment for strongylosis?
Ivermectin and albendazole.
Okay, yes, very good. And what's the treatment for vaginal candidiasis?
Fluconazole.
Yes, any antifungal, right? Okay. Okay, Dr. Elizabeth Sharkar, can you hear me?
Yes, miss.
Okay, so can you tell me the treatment protocol for gonorrhea infection?
Usually ceftriaxone 500 milligram intravascular in a single dose, or azithromycin 1 gram oral as a single dose.
It's usually the combination because synergistically we are trying to treat the chlamydia infection at the same time. Okay. All right.
Thank you.
Okay, for schistosomiasis, there are several types of schistosomia infection. One is schistosomiasis mansoni, japonicum, intercalatum, hematobium. Okay, hematobium is the only one that affects the urinary bladder, and schistosomia mansoni and intercalatum causes intestinal schistosomiasis. Japonicum can also involve the liver as well. Schistosomia hematobium, what it does is the worm deposits egg cluster, okay, which is also known as the pseudopapilloma in the bladder, thereby causing inflammation in the bladder neck. And sometimes this eggs cluster can be seen as calcification on the X-ray. This is not really a calcification of the urinary bladder. This is just the eggs of the worm. Okay, and usually they can resemble like that of urinary bladder cancer. It is a risk factor for squamous cell cancer in the bladder, but it can also mimic the cancer symptoms because in schistosomia hematobium, what happens is hematuria, blood clot, fever, abdominal pain, and dysuria. Also, it can be a risk factor for the squamous cell cancer. Which cancer is most common in the bladder? Transitional cell cancer. Okay, very good. But schistosomia hematobium causes squamous cell cancer. Okay, so it can present like the lower urinary tract like features like frequency, hematuria, bladder calcification, all this. Single dose of praziquantel is used in case of schistosomiasis. Mansoni and japonicum can mature in the liver and travel through the portal system to inhabit the distal colon. So they can cause colitis and they can cause features resembling like that of CLD because they will be invading the portal system, causing portal obstruction, thereby mimicking the portal hypertension caused by CLD as well. Progressive hepatomegaly, splenomegaly due to portal vein congestion, okay? And for the intercalatum and the Mekong, it's not really that important. Trypanosomiasis, there are two varieties, African and American. African trypanosomiasis causes sleeping sickness, and American one causes Chagas disease. Important, I think, like in which condition the heart is involved. Chagas disease, yes, very good. And megacolon, megaesophagus, these are seen in Chagas disease as well. Okay. And African trypanosomiasis usually causes neurological symptoms more. That's why this is known as the sleeping sickness. Malaria, okay, malaria is quite, I would say, 2-star important topic for part 1 examination. Features of severe malaria, this is important. Size on the blood film. If the parasite load is more than 2%, if there is development of hypoglycemia, high-grade fever more than 39%, severe anemia, because malaria, this, like parasite, they tend to involve the red blood cell, okay, thereby causing the mechanical destruction of the red blood cell and causing hemolysis. It's one of the causes of hemolytic anemia, okay. So severe anemia is a feature of severe malaria. Complication, it can cause cerebral malaria, very bad, particularly in our country from the Chittagong or the hilly area. We commonly encounter these kind of patients. It can also cause acute renal failure in the form of black water fever. And this occurs because of the intravascular hemolysis. And there is development of ARDS, hypoglycemia, DIC. These are the complications, okay? Uncomplicated, for the treatment purpose, we will try to keep it quite simple, okay? You don't have to remember the doses. Just remember if it's a case of Plasmodium falciparum or non-falciparum. If this is a case of Plasmodium falciparum, then try to divide it into this is complicated or uncomplicated. If this is uncomplicated, then it's an ACT-based treatment. What is that? Artesunate-based treatment. So it can be artesunate plus a combination of another antimalarial, like artesunate mefloquine. This is a common combination, and artesunate plus proguanil. These are common combination, okay? And in case of the severe falciparum malaria, treatment is usually IV artesunate. In uncomplicated, oral ACT-based treatment. In complicated variety, IV artesunate rather than IV quinine. And importance is, if this is more than 2%, usually parenteral treatment. And if the parasite count is more than 10%, then we go for exchange transfusion. Okay. For the non-falciparum, Vivex, Plasmodium ovale, and Plasmodium malari. These are the common causes. Vivex and ovale, they have hypnozoids. They remain dormant. Where? Liver. Yes, very good. And Plasmodium vivex is often found in the Central America, Indian subcontinent, and ovale is typically found in Africa. In our country, falciparum is more common, okay? In India and in America, in Central America particularly, Vivex is more common. In the Africa, Plasmodium ovale is more common, okay? Malaria fever, how does it resemble? High-grade fever, showing a quotidian, diquotidian, right? What was that? Intermittent fever characteristic, every 48 hours, fever coming on and off. Cyclical fever, see, every 48 hours. And Plasmodium malari comes like every 72 hours. So every 3 days after the fever will be coming. Fever, headache, splenomegaly, hepatosplenomegaly can also be caused by malaria infection. Okay, Plasmodium malari is also associated with nephrotic syndrome, especially membranous glomerulonephritis. Okay, ovale and vivex malaria have a hypnozoid stage and therefore may relapse even following treatment. So that's why we treat with primaquine. Yes. And in case of the non-falciparum malari, treatment is usually ACT based here as well. And most of these are quinine sensitive. So that's why you can go for the ACT. No other combination therapy is required here. However, ACTs should be avoided in the pregnant women. So what's the treatment for pregnant women? Chloroquine can be given in pregnant women, okay? Patients with ovally or vivax malaria should be given primaquine following an acute treatment with chloroquine to destroy the liver hypnozoite. This is important, okay? Malaria investigation, one simple word, thick film, thin film. Thick film is sensitive, thin film is showing the species. Apart from that, other tests like RDT or the rapid diagnostic test, rapid antigen test, these are available. Thrombocythemia, normochromic normocytic anemia, WBC count is usually normal, and as there is huge hemolysis, the reticulocyte count will be increased here. So for investigation purpose, remember thick film, thin film, RDT, okay? And for treatment purpose, divide it into whether this is falciparum, non-falciparum. If this is falciparum, is it complicated, uncomplicated? Uncomplicated, ACT plus another antimalarial. And if this is complicated, then IV artesunate or IV quinine, depending on the availability. Usually IV artesunate is more superior than IV quinine. If the parasite count is more than 10%, then exchange transfusion. Non-falciparum malaria treatment, what will be? Just ACT. Chloroquine or just ACT. And after the treatment with Vivax and Ovali, primaquine. Okay. All right, malaria profile exists. Now, this is a bit complicated. Just remember the name of the drug, like which are the combination of the drugs that are available for profile exists. Like Malarone, this is a commonly used, but it causes severe GI upset. So that's why usually the mefloquine, doxycycline or chloroquine, these are used as a prophylactic. Most of this prophylaxis starts from 1 week before the traveling and 4 weeks after coming back from the travel, except for the Malarone. Except for the Malarone, which is taken 1 to 2 days before the traveling and only 7 days after coming back from the travel. Chloroquine, this is contraindicated in epilepsy. Important information. Mefloquine can sometimes cause neuropsychiatric disturbance. So after taking mefloquine, a patient might be having bizarre dreams, nightmare, night terrors, and show like psychiatric episode. So that's why a lot of the like health regulation are saying that mefloquine should be banned for as prophylactic means. Pregnant women should be advised to travel in the endemic region. However, if this is very important to travel in the endemic region, then chloroquine can be taken, okay? Proguanil, anything can be taken apart from mefloquine and doxycycline, okay? So which one of the prophylactic medication can cause abnormal psychiatric behavior? Mefloquine, okay. And which of the medication is contraindicated in pregnancy? Antimalarial? ACT in general, okay, but for prophylactic basis, mefloquine should be used with caution, and doxycycline. Doxycycline is contraindicated in pregnancy. Okay. Leishmaniasis, what does it do? Kala-azar. There are 3 different types of leishmaniasis. One is cutaneous, mucocutaneous, and visceral. Visceral leishmaniasis is known as Kala-azar, Leishmania donovani, okay? And cutaneous leishmaniasis is caused by Leishmania tropica or Leishmania mexicana. Crusted lesion at the site of the bite, and there might be underlying ulcer. Mucocutaneous looks horrible. If you go through the Google, mucocutaneous leishmaniasis looks the most horrible. Caused by Leishmania brasiliensis, skin lesions may spread into the mucosa of the nose, pharynx, larynx. Even the mucosal surface of the eyes can be involved as well. Visceral leishmaniasis, what does it do? Fever, anemia, hepatosplenomegaly, bony tenderness, myelosuppression, okay? And slate gray pigmentation in the body. That's why this is known as Kala-azar. Just give it a read. It's quite just not that important. Sometimes some questions can come from the mucocutaneous leishmaniasis and the treatment for the visceral leishmaniasis. Like for visceral leishmaniasis, the treatment protocol is liposomal amphotericin B or miltefosine. And for the mucocutaneous leishmaniasis, sodium, I think sodium stevogluconate. And for the cutaneous, topical paromomycin or topical paromomycin, sodium stibogluconate. Like basically cutaneous and mucocutaneous treatment is quite similar. Sodium stibogluconate, and for the visceral, liposomal amphotericin B. Investigation for calazoid, that is important. Investigation is you can rapid antigen detecting test or direct agglutination test, DAT, RK39 antigen test. These can be used, okay? Serology and antigen and antibody detection. All right, I think we do have like, I will just read about 2 more topics and then I will go a recapitulation. Okay, giardiasis, this is caused by flagellate protozoa known as Giardia lamblia. This is more a common cause of diarrhea in diabetic patient, okay? This is spread by the fecal-oral route, often asymptomatic. It causes watery diarrhea, but sometimes in the long stages, it can also cause malabsorptive type of diarrhea. But giardia will never cause dirty diarrhea. Okay, and stool microscopy or for the trophozoidal cyst can be classically negative. That's why duodenal aspirate, like doing an upper GI endoscopy and taking that aspirate and going for a preparing that duodenal aspirate to see the microscopy or the staining that can detect the giardia lamblia. Sometimes string test is also done because endoscopy can be quite painful. So in that case, if you just go for like a normal string test, after swallowing that, we take it out and go for the aspirate testing. Okay, treatment is with metronidazole. This is an anaerobic organism, that's why. Anaerobic infection, protozoa, important treatment is metronidazole. Toxoplasmosis, this is a protozoal infection caused by Toxoplasma gondii. Where is it mostly present? It's present in the cat feces. It can affect humans by, if somehow from the cat feces this is consumed by humans. Not technically, like for example, you have just cleaned out the cat's litter. You have been contaminated. Maybe imagine the cat has been contaminated with Toxoplasmosis gondii. You have cleaned the filter and you haven't washed your hand. Now you are starting to take like your food or something. A lot of cat owners do that, okay? Like they do not directly touch the poop, but they just scoop that out and they think that, okay, like my hands are like sanitized. But if you, without washing your hand properly, if you try to take some food, then you can be contaminated with this. Normally, individuals, Toxoplasma gondii usually does not cause any symptom. It causes symptoms in the immunocompromised patients. And not just that, like if the cat feces is not like properly cleaned, and if you inhale, not the feces itself, but inhale the air surrounding that area, it can also affect you. So through the fecal-oral route, through inhalation route, and even sometimes skin breaches, this Toxoplasma gondii protozoa can enter into the body. So it can affect the body via the GI tract, lung, or the broken skin. This oocyst release trophozoites, which migrate widely around the body, including the eye, brain, and the muscle. The usual animal reservoir is the cat, although other animals such as rats can carry the disease. Most infections are asymptomatic and self-limiting. However, in immunocompromised patients, it can cause severe manifestation. One of the commonest complications being, in HIV patients, it can cause meningoencephalitis and showing ring-like enhancing shadows. Yes. It can also affect the heart as well, myocarditis. Investigation, antibody test, and Sabin dye test. Treatment is reserved for those with severe infection or symptomatic patient and patients who are immunocompromised. Treatment is with pyrimethamine plus sulfadiazine for at least 6 weeks. Congenital toxoplasmosis is due to transplacental spread from the mother. It causes a variety of effects to the unborn child, including microcephaly, hydrocephalus, cerebral calcification, and choroidoretinitis. Okay, so complications of congenital toxoplasmosis are mostly CNS complication: microcephaly, hydrocephalus, cerebral calcification, and choroidoretinitis. Treatment is pyrimethamine and sulfadiazine for 6 weeks. Test is antibody test, like you can go for the ELISA test or Sabin dye test. Sabin dye test is not nowadays used, antibody test is used more. Okay, so far, I will start with HIV from tomorrow. I think I'm done with the lecture for today. So I'm just going to give you like a general brief discussion idea. So today we have discussed about, first of all, syphilis. Basically, spirochete infections. Syphilis. Number 2, Lyme's disease, very, very important topic. Number 3, we have discussed about leptospirosis. So usually in spirochete infection, benzyl penicillin is the treatment, except for Lyme's disease. Here the treatment is doxycycline. Okay. Number 4, we have discussed about gastroenteritis. Most of the gastroenteritis condition, these are anaerobes. Okay, so treatment is usually Cipro, except for Giardia, because this is a protozoal infection, right? So treatment is metronidazole. Commonest cause of traveler's diarrhea, which one? E. coli. Okay. Commonest cause of diarrhea in the UK, Campylobacter jejuni. Treatment is? No? Which one? Campylobacter jejuni? The reason why I'm writing down, because these are different. Treatment is clarithromycin. Okay? All right. So which one causes bloody diarrhea? Salmonella, Shigella, and E. coli, not all the strain, only the hemolytic uremic syndrome strain will cause that. Apart from that, it's usually watery diarrhea. And Campylobacter jejuni and Yersinia pestis. I haven't discussed about this, but Yersinia pestis can also cause bloody diarrhea. Does Giardia cause bloody diarrhea? No. Giardia usually causes either watery diarrhea for a long time or malabsorptive diarrhea. Okay. And amoebiasis. What's the treatment for amoebiasis? Metro. It can affect either intestine, causing intestinal dysentery, also cause liver abscess. Okay. Then nematode, among the nematode, strongyloidosis. Treatment is ivermectin plus albendazole. Okay. Schistosomiasis. Schistosomus hematobium. What does it cause? Increases the risk of squamous cell cancer of the urinary bladder. In urinary bladder. What's the treatment for schistosomiasis? Praziquantel. Okay. Number 10. Painful genital ulcer. Painful genital ulcer. Which one? Herpes simplex and chancroid. Chancre is? Chancre?
Propellus UK.
Syphilis. Yes. Chancre is painful or painless? Painless. Yes. And chancroid? Painful. Very good. LGV caused by chlamydia trachomatis. It causes painless ulcer but painful lymph node. Okay. Chlamydia infection treatment. Chlamydia. Doxy and doxy, or single dose of azith. Okay. Gonorrhea. Intramuscular ceftriaxone plus as it. Why as it given? To cover the chlamydia infection. Partner notification is very important for any of this sexually transmitted infection. Okay. Vaginal discharge. Candida, cottage cheese like thick, causes itchiness more. Treatment is any antifungal. Okay. And bacterial vaginosis caused by Gardnerella, causes fishy odor. Treatment is Metro. Trichomonas, itching is more common. Frothy discharge. Treatment is same, Metro. Okay. And let's see. Do I still have anything left? Okay. Malaria. Malaria and Kalas or treatment. For malaria, falciparum, non-falciparum. Complicated, uncomplicated, this is complicated. Non-falciparum treatment. Okay, first of all, let's see falciparum treatment. Uncomplicated, which one? ACT plus other. Okay, and for the complicated, IV, ACT or artesunate. Okay, non-falciparum treatment is chloroquine, basically chloroquine plus primaquine. Okay, good. For Kalas or treatment, if this is cutaneous or mucocutaneous, treatment is sodium stibogluconate, and if this is visceral, amphotericin. Yes. What's the, okay, Dr. Kobe, what's the treatment for leptospirosis? You weren't there, right? No, leptospirosis, Will's disease. No, you weren't present there that time. Obijit, Dr. Obijit? Yes, amoxicillin or benzyl penicillin. Okay. Any spirochete infection, first line treatment is benzyl penicillin, except for Lyme's disease, doxycycline. Okay. All right, I think that's so far I have discussed. Try to make a like chart back in your home and then go through these topics again from your book. I hope my lecture was a bit enjoyable today. In the next class, I will try to go through, I will try to make some questions from past test, or maybe I will use some question from the back of your question bank as well. And it will be like 15 to 20 question, maybe even less, depending on the time I have. And I will do like a very rapid question answer session at the end of my lecture, from starting from 6 to 6:30 p.m. Okay, so try to be prepared. And I would say, like, people who are attending my class online or in person at this moment, try to be a bit more spontaneous. Do not be afraid of giving the wrong answer. Okay, it's okay, completely okay to give the wrong answer, but do not go through the books and then give me the bookish answer. Okay, just try to be spontaneous. Even if it is wrong, it's entirely fine, no problem. Okay, so far, any questions for me? Okay, yes, I will try to cover this, like, especially there are a handful of like maybe 8 to 9 diseases only that is very stereotypically located to the geographical distribution. I will try to write that down, okay, and give you that. All right, so if no more question, I'm concluding our today's session. You can ask me any question. And in the very beginning part of our discussion today, I have gone through the resources you should be using. Try to go through the lecture note. Okay, it's very good. And at the end of the lecture note, there are some questions related to today's topic. Try to go through this question, okay, solve at least once. Then you will be seeing that, okay, question answers are not that scary. If you go through this question after I'm done with entire lecture, then it will be becoming a bit haphazard for you. So try to solve the questions at this instant. Okay, thank you all. Bye.